percutaneously. The surgeon had done it surgically during mitral valve surgery for quite a while, but since the patient usually got the metallic mitral valve, he or she needed atrial anticoagulation anyhow, so they were not really interested in following those patients up. But Michael Lesh had the idea. He created this device, the Pla2 device, and he did the first implantation under general anesthesia, TE, you name it. It was almost like an operative procedure, a very complex device on August 30, 2001, 10 years ago, with Horst Sievert in Frankfurt. We also started months later at Bern, and I thought this was very complex, and I remember that using Amplatzer ASD devices like we just did, that occasionally I wanted to place them here in the ASD, but I opened the left disc up too far out, and it got stuck in the left atrial appendage, and I had to kind of really pull it out to finish my ASD closure. So I said, why not use this principle? And I called that pacifier principle, you know, leave the left disc in here somewhat distorted, but retaining the device, and use the right disc for a nice snug closure, which in the last case was not quite as nice because the right disc was fairly small due to the fact that we had to use a very small left disc. And then I went to pathology and tried it, and it worked in quite, not every patient, but it worked quite well. And so we then started the first case. This is what it looks like, a TE follow-up. You see the left atrial appendage is no longer there, and you see this pacifier kind of being in the mouth of the left atrial appendage. So on June 15, 2002, we actually did the world's first left atrial appendage closure in an awake patient without echo guidance, exactly the way we saw it now with a somewhat larger device. It was a butcher who didn't want warfarin because when he cut himself, he was bleeding for an hour and he could not continue working with his own hand bleeding. So he said, I need to have no warfarin, so I need to have this technique. And it worked beautifully, and I thought that this was the end of the story, and the problem was solved. Amplatzer or cocoon devices, as you use them here, are very easy to use, as you can see. And so this is the first case, and it looked beautiful after 1 year. TE, exactly what you want, you know, the plate occluding it, no clot on the device, and the left disc somewhat here, filling in the left atrial appendage. The patient now is 10 years out. He's still fine. He's retired by now, but he has never used warfarin any longer and has not had any embolic event since. Now these, so the devices that came about first, the Pla2, which unfortunately, or maybe not unfortunately, because it was not a very good device. It did have some hooks here, but it was very stiff and could not close more than about 80% of the left atrial appendage. So it was actually discontinued. So the Amplatzer technique is the next one that has survived. By now the device looks different. It has these hooks added. The shape is a little bit different, adapted to the left atrial appendage. We kind of, together with Kurt Amplatzer, worked on those molds, and finally I got him to put the hooks. He resisted to put hooks until I had embolized about 10 of the non-hook devices, and then he finally agreed to put some hooks, and I think hooks are essential. And then came the Watchman also in 2002. A little later the Watchman was introduced, also having some hooks. And in Europe we can also use a completely different method from a Greek company, which however is only used by some Greek doctors. Here you see the Amplatzer cardiac block as it is used today, with this lobe here with the hooks, retaining hooks, and the disc, which is larger than the lobe because it should close off, as in the pacifier principle, the entrance of the left atrial appendage. The Watchman is placed somewhere here, so you always have some remaining entrance that is not covered with the Watchman. With this technique, if you do well, you can cover the entire orifice. So this is another example with now this dedicated device, and you can see that this is again a bilobar, not unlike the lady we just had, and we put again the left lobe into the larger lobe of the LA, which looked like a strawberry, just like we had it today. But of course here you have the hooks. These markers indicate where the hooks grab. So the the hooks grab above the marker, so there are hooks grabbing here, and this is quite safe. Without the hooks, you're always a bit worried that the strawberry might kind of be spit out, particularly if the left atrial appendage is still in sinus rhythm and contracting. And here you see the 3 months TE follow-up with this pacifier, occluding the left atrial appendage exactly the way you wanted. Now, the transeptal puncture, we talked about this during the case. We had done it before live, just to save some time. And you can see that with echo, 2-dimensional or even 3-dimensional, you can very nicely show the tenting of your needle. That's a nice method, but it takes intracardiac or transesophageal echo. Both are, one is costly and creates some additional puncture problems, and the other one is uncomfortable and may need intubation of the patient. So rather than doing that, and we also discussed that maybe the fossa oralis is not the best place to puncture. The best place to puncture would probably be here, where you have some muscles, where of course the hole will close, and where you have a more straight approach to the left atrial appendage. But any place from here to here, even here, it's probably okay if you puncture through the septum secundum. Now, as you see, without echo, we do it just by doing some dissection. You see it here again, we're in a muscular portion. You see the tenting also, and you just keep on pushing and twisting a bit left and right, and finally you see when you get through that you're in the left atrium. And here is a case where we went through the thin part, and at 3 months there was a small ASD as a remnant of the left atrial appendage occlusion, but this patient for some reason had another TE 3 months later, and you can see that this shunt had disappeared. It was no longer there. So even in the membranous part comes time, those small ASDs can close. Now there are other stages as a PFO for paradoxical emboli, because the clots coming from the inferior vena cava will easily go through the PFO, but they are unlikely to turn left here and go against the flow through a small hole. So they're not really, you don't have to close them for prevention of paradoxical stroke, and you do not have to close them for size because they are small, and as you can see, they might close spontaneously as time goes by. Now, electrophysiology sometimes reprimand us because we close a lot of PFOs. That's another topic, but we close the PFO whenever we know that it's there. It's very easy to close. There are no mistakes. There are no complications with this technique, but then they tell us, well, if the patient develops atrial fibrillation later in life, how can we ablate? Very easily. You can see that from here down to here, there's a safe place to do your transeptal puncture. So just, if the patient has a PFO device, just put it in this projection in the cath lab and use your transeptal puncture right underneath the disc. You're in an absolutely safe place. Up to down here, it's a safe place to puncture. So it actually helps. It's a bit different if you have an ASD device that may go from here to here. Then of course it may get more difficult, but with PFO closure you are certainly not preventing ablation later, you're actually helping the transeptal puncture if it's going to be. Just going through another case as you saw it today, you see this is first the transeptal puncture, again staining it, and then you see exactly when you get through. Here we probably get through the septum secundum. This is probably the septum primum. Fossa oralis is here, so we're a bit high, but we're in the muscular part of the septum. This was an easy LAA. If they go this way, they're easy. If they turn back the other way, they're more difficult. Yes?
Buddy, we have a minute left to end the session.
Okay, I'll be finished, I guess. So we go through this, you do the injection here, and this was in sinus rhythm. Then you place the device, just pushing out the left disc first, and the sheet will move back automatically. Don't pull it back, then you pull the sheet back for the right disc. Then you do this dissection in the good projection where the two parts are separated, and then you do your wiggling here. Of course, the hooks give you more security. You're not going to pull it out, and then you do your release. And after the release, you do a final injection to make sure that you achieve what you want. Now, of course, as I said, since this was with a non-dedicated device, this patient had a PFO, it lends itself to close the PFO on the way out. And here you can see the LAA closure device at the follow-up 6 months TEE, and you see the PFO device. Both are in good shape, and this is a perfect result of both. And there may be thrombus more than you have on a PFO device because they're not in sinus rhythm. And of course, if you see that, you may have to use anticoagulation. The PFO device was clean in this case, but the there was another case who had both, but the LAA device had this club on the screw. And you can see that after some months of anticoagulation, both the LAA device and the PFO device stayed clean, and this one got clean. But this is about 10 times more common to have clots. This is our treasure case where in one setting in an 84-year-old woman, we put in a biometric stent in the LAD, we put in an LAA closure device, we put in an ASD device on the way out, she also had an ASD, and we put in an aortic valve. And this was done with an awake patient in one-stop shop intervention. Now let me just briefly on the long-term outcome, it works, but let me just go to our own data. You see with our own data with the implanted device and about 200 years of follow-up, you can see that if we had no anticoagulation and no occlusion, those patients, based on the CHED score, we would have expected 5.5 events, which we put as 100%. Now, if we had used anticoagulation just based on the CHED score, we would have expected 1.8 events in those 200 patient years. And so warfarin would theoretically have reduced it by 74%. What we really saw was one embolic event. So we reduced it actually further than warfarin would have reduced it. And we also did this with the dedicated plug, where we have fewer follow-up, and you can see the same thing. Warfarin would have reduced it to this, and we had no embolic event in those patients. So the principle works. Just a word on the Watchman. You all know the Protect AF randomized trial, which showed that at 3 years, warfarin was still a little better, but only because of the complication of the intervention. If you abstract from that, actually the Watchman was better than the control. And as you can see, those complications became fewer while they were learning. So this is the last registry with much less complications than they had in the AF trial. And they also modified since the device, which will be coming soon. Of course, the hooks are still there, and the barbs, as they call them, are an important feature of this device. And there will be another one coming, but this is maybe too much to talk about. It's going to take another year. So left atrial appendage closure in atrial fibrillation, an issue with an open issue. Thank you.
Thank you very much, Meier.
One thing also I forgot to mention, why not combine the two things? You know, warfarin brings down the risk to have. If you put in an additional left atrial appendage occluder, maybe the risk is even smaller, but this is just an idea that may be pursued later on.
Thank you, Dr. Meier, for the excellent presentation of the case and the lecture. In the interest of time, we will not have any further questions. Thank you very much. Please give a big hand.
Thank you very much.
Thank you to our chair and panelist of the session. Our next, my most challenging case is by invitation, state of the art. Chairpersons, may I please call the following chairpersons of the dais.